All right, good evening. And I think we're just letting some more people attend. Hopefully everyone can log in with us. But good evening, I am Leslie Tierney. I'm the Vice President of Operations for the Lupus Foundation of America, Greater Ohio chapter. Tonight, we are joined together with our chapter of network of the Lupus Foundation of America, and we welcome everyone to join us. So just as a reminder, all lines are muted to ensure the quality of the audio and provide a distraction-free learning environment. At the end of this webinar, there will be an evaluation, and we'll actually select 3 winners for 3 different gift cards. I think the prizes are, a premium Spotify gift card, a $50 Amazon gift card, and a $25 Starbucks gift card. So that's fun. And a quick disclaimer here. Before we start the presentation, we have a disclaimer. Your physician is the best person to help you in the treatment of lupus. The information you learn here today can be discussed with your doctor, as your physician knows your medical history best. Please do not make any medical changes without consulting your physician first. So, okay, that brings us to our presentation tonight. Joining us today is Dr. Blatt. Dr. Blatt is a service line chief medical director at Indiana University Health Physicians Rheumatology. After receiving his bachelor's degree in science from Penn State University, he graduated from Jefferson Medical College of Philadelphia and did an internship and residency at Methodist Hospital in Indianapolis. His fellowship in rheumatology was completed at Indiana University Medical Center. Dr. Blatt is a board-certified internal medicine and rheumatology, and is a member of the Marion County Medical Society, Indiana State Medical Association, American College of Rheumatology. Dr. Blatt serves as numerous speakers and bureaus and has been named a 6-time Indianapolis Monthly Magazine list of top docs. Well, thank you, Dr. Blatt, for joining us. And
My pleasure.
Yeah, today we are talking about hydroxychloroquine, and fact or fiction is our topic. And so we really appreciate you being here today. And many people have submitted questions ahead of time for us to kind of go through and just address what this hot topic is. I mean, hydroxychloroquine has been in the news lines for quite some time, and we're all home listening to it. So could you please give us the basic understanding of hydroxychloroquine?
Sure. Well, thank you, Leslie, for inviting me. And thank you, everybody who came on tonight to listen. I know these are rather unusual times with this COVID-19. And because of that, and because of some of the concerns about hydroxychloroquine with the treatment, I think that's led to some of the concerns that some of you have, and we will try to allay those concerns. So first of all, in terms of the efficacy of hydroxychloroquine, which brand name is Plaquenil, this is a drug that has been used to treat lupus for longer than I've been in practice or in training, and we're probably talking about somewhere in the 60 to 70 year range. It is our most basic and important drug that essentially all patients with lupus should be on, unless there is a significant reason not to be on it. And we'll talk about some of those later when we get the side effects. The drug actually was used initially for malaria and was found many years ago to be effective for lupus and also used in rheumatoid arthritis. It's very interesting that no one knows exactly the entire mechanism of how it works. And as you know, when there's different theories on how something works, that means no one really knows for sure. But basically, it has an effect on immune cells. It's not really an immunosuppressive. So patients that take lupus are really not immunosuppressed, but it has a slight what's called modulating effect on cells that are important in lupus. It also has effects on the liver cells and decreases the body's ability to make cholesterol. It also has a very mild anticoagulant effect in people, and that reduces risk of heart disease and reduces risk of stroke. And as you know, patients with lupus are at a higher risk of having clotting abnormalities than the general population. In general, unless again, there's a reason not to be on it, which your physician says you should not be on it, all patients should be on Plaquenil. Studies have shown that thousands of patients who took Plaquenil versus thousands of lupus patients who did not take Plaquenil. Those that did not take Plaquenil had more serious organ disease and more morbidity, worsening of the condition over a period of 10 or 15 years.
Well, so a couple questions that have been submitted, and we'll just kind of run through them together if that's okay with you.
That's fine.
You've hit a little, you've definitely hit upon them, but we talked about how Plaquenil is helpful for lupus patients. You've already said, you know, the mechanism is truly not known, that's what I'm hearing, but that it's helpful for patients in the morbidity rate. You know I don't look it, but I've been with the foundation for many years, and I would say I've heard prior to Plaquenil being prescribed for lupus patients that many patients were facing fatalities, and now that's not so true anymore. Patients are living well being on Plaquenil.
Exactly.
And so another question someone submitted was, I've heard hydroxychloroquine referred to as the cornerstone of medication for people with lupus. Why is this?
That is true, because again, it is the single most important drug that lupus patients should be on to try to forestall long-term consequences of the disease. It is also extremely safe. And when you look at the pyramid and hierarchy of all the other medications that we use for Plaquenil, and everyone listening, if you have lupus or you know someone with lupus, you'll be familiar with these drugs. Corticosteroids, they are life-saving in certain conditions, in certain situations with lupus. But in general, steroids long-term are not a lupus patient's friend. Steroids lead to more infections, cardiovascular disease, and other abnormalities. So steroids are great for short periods of time, and sometimes we have to use low doses long-term, but they're not in your best interest. Drugs such as methotrexate, drugs such as Imuran, azathioprine, drugs such as Cellcept, mycophenolate, drugs such as Prograf, drugs such as Benlysta, drugs such as Rituxan, drugs such as cyclophosphamide. These are all drugs that are used to treat patients with lupus. And virtually all of these have potential side effects. And I dare say that the side effects of those drugs are much greater than the potential side effects of lupus. And again, we're going to talk in a little while in detail about side effect profile, etc. But suffice it to say, the benefit ratio of benefit to toxicity of Plaquenil is so far in favor of the benefit that, again, I'll reiterate for the third time, unless there's a reason that your physician does not want you to take Plaquenil, every patient with systemic lupus should be on Plaquenil.
Wow. Okay, thank you. If a patient can't be on it, are there different types of medication that can replace hydroxychloroquine? I know you mentioned many, but is there a medication that could replace it?
Well, that's kind of the sad situation. Plaquenil is so safe that we use it in everybody. Patients with mild lupus many times can get along just with Plaquenil alone, and maybe a little Tylenol or a little ibuprofen or naproxen. If Plaquenil is not available, then there's kind of a void there. There's nothing that's at the same level in terms of safety. So if you're not on Plaquenil, you either have to go without medications, which can lead to potential problems, or you have to go on stronger medicines, which are more potent than what you really need. And then those drugs have side effect profiles that I don't like to have patients be exposed to if they don't have to be. But again, there are some select situations where Plaquenil cannot be used. And in those cases, we kind of have to improvise.
Okay, all right. What medications are contraindicated with Plaquenil or hydroxychloroquine?
So I'm not really aware of anything that you can't take when you're taking Plaquenil. Okay. All of the major immunosuppressives can be used with it. Steroids can be used with it. Non-steroidals can be used with it. I would say that, and we'll talk about this a little later with the COVID-19 data, that maybe, just maybe, certain drugs such as azithromycin or Zithromax, you may not want to use with Plaquenil because both of them potentially can have an effect on the conduction system of the heart, and there would be a very, very, very small risk of an arrhythmia. So I would say everyone should take their Plaquenil, but if you needed an antibiotic, then maybe your physician might think about using a different drug other than Zithromax. But again, I've seen many patients with Plaquenil, on Plaquenil, take Zithromax without a problem, but it could be a potential theoretical situation. But other than that, I really don't think of anything that would be a contraindication with it.
Okay. Is it possible to overdose on Plaquenil?
The question is it possible to overdose? So the use of Plaquenil in lupus and rheumatoid arthritis is based on weight. And if one is over 135 to 140 pounds, we usually use 400 milligrams a day. In anybody under 135 pounds, we usually use 200 milligrams a day. So those are the standard doses. If you take higher doses, if you're 95 pounds and you're taking 400 milligrams of Plaquenil, I wouldn't say you get an overdose from it, but it does increase the potential for retinal toxicity, which we'll talk about later. If someone ingested an entire bottle of 60 pills, I don't know what it would do. I've never been faced with that situation. So it's not a drug that I would think that it would have a serious problem if you tried to do yourself in, so to speak. But I don't have any information about that. The information I have is that if one is taking a higher than accepted level of medication for your weight, it increases the potential risk of retinal toxicity.
Okay, that's understandable there. All right, well, I'd like to start getting into the availability of hydroxychloroquine. So there's a lot of hot news out there and patients experiencing certain aspects of obtaining the medication, refilling their prescriptions, but can you talk a little bit about the availability of hydroxychloroquine?
Okay, so with hydroxychloroquine, for many, many years, there's never been a problem with it. I found out actually about 2 or 3 years ago that patients, and many of you out there know this, were starting to find that the cost was going up. And that's because there were less and less generic companies making hydroxychloroquine. Very few make the actually brand name Plaquenil anymore. And for all intents and purposes, all of my patients are on the generic. And everything was fine until the pandemic. And then somewhere there was some science, supposedly, that hydroxychloroquine in the test tube may have reduced the activity of the COVID-19 virus. So it was fast-tracked to some clinical studies. The bottom line of those clinical studies is that there is no evidence whatsoever that taking Plaquenil hydroxychloroquine will prevent will prevent COVID-19.
Right.
And there is no data that taking hydroxychloroquine in someone who is very sick in the hospital, maybe about to go on a ventilator, will improve. And in fact, the data is the opposite, that if you take it, you actually increase your risk of having a significant negative effect from the drug. Part of the hype on this was proposed by, and I don't mean to get political here, but it was proposed by the President of the United States, who is not a physician, and so you should not listen to him for any medical advice. Plaquenil should not be used to prevent or treat COVID-19. Since that data has come out recently, I have found that many of my patients who are having trouble getting Plaquenil have now found it easier to get. But for those of you who are having a problem, this is what I recommend. Number one, have your rheumatologist who is writing for it write for the prescription and put the diagnostic code for SLE on the prescription. We use M32.9. And many pharmacies, at least in the Indianapolis area, are grandfathering and grandmothering patients in. If they've been receiving Plaquenil for a long period of time, they're filling it. And they're actually being a little hesitant to fill new prescriptions that come out of the blue, especially if it's from a physician who is not a rheumatologist. So that has helped. In other areas, one of the other things I have found is going through the Canadian mail order system is also a good way to get Plaquenil because there doesn't seem to be a shortage in Canada. And there are several mail orders such as CanDrug, another one called RX Connect. All of these can be looked up on the interstate. So for all intents and purposes, other than about a week or two, probably in the third week of March, I will go knock on wood, I have not had any problem with any of my patients receiving Plaquenil. The other thing, if you're really in distress, is this. Hydroxychloroquine stays in your system for 60 days. If you're taking 400 milligrams daily and you just cannot get it, taking one pill every other day would last you for months and months and months if you had a supply of 50 or 60 pills until the shortage goes away. But trust me, I think the shortage of hydroxychloroquine / Plaquenil is going to stop very quickly, and we'll be back to square one where we were pre-COVID-19.
Okay, all right. Well, I have a longer question here. So again, patients submitted questions ahead of time. And this is, why can't each state be forced to provide access to patients who have been on it for lupus upon doctor's prescriptions and authorizing? Sorry. I keep reading the guidelines that vary from state to state on whether pharmacists can withhold it legally. So I guess it's, why can't the state enforce that patients should be getting their medication?
So I am not a lawyer, but basically my understanding is that when the FDA approves a drug for consumption by the public and a physician writes for that drug, unless the pharmacist finds that there is a significant potential drug-drug interaction between drug A, which is being prescribed, and something else the patient's on, and contacts the physician about it, my understanding is the pharmacist does not have any legal ability to rely on saying, I'm not going to give this drug to this patient because the doctor is the one that writes the prescription. And different states have different rules about this. Again, I'm not a legal scholar, but I will say, as I mentioned a few moments ago, that at least locally here in my community, I found that some of the pharmacists are requiring that you put the diagnostic code of the disease on the prescription to fill it. And so they are in some way kind of preferentially filling the prescriptions for patients with lupus and rheumatoid arthritis over someone who just goes to their primary care physician who doesn't have an arthritic condition and asks for Plaquenil to be prescribed. But again, the pharmacists don't really have the right to refuse filling a prescription if it's FDA approved and it's written by a licensed physician.
So what might happen if a patient abruptly just stopped the medication altogether?
So as I said, the medication stays in your body for at least 2 months. So nothing untoward would happen immediately. Now, after a period of several months, it really depends on why is the patient on Plaquenil? For what manifestations of lupus? So I'll give you an example. Someone's on Plaquenil because of hair loss, and I relate to that. Maybe some mouth ulcers, maybe some joint disease, and maybe a skin rash. And they're taking naproxen or ibuprofen or something along with Plaquenil, and you stop the Plaquenil. And 3 or 4 months later, maybe the rash will get worse, maybe the arthritis will get worse, maybe the hair loss will get worse, but nothing is going to happen immediately. Now you take a patient who has more severe disease. They may have heart disease, lung disease, kidney disease, brain disease, all sorts of serious manifestations of lupus, and they're on immunosuppressive agents. Maybe they're on Imuran, azathioprine. Maybe they're on Cellcept, mycophenolate. Maybe they're on some steroids, and you stop the Plaquenil. Well, again, you're probably not going to see anything untoward happen quickly, and probably not even for months and months and months, because these patients are on drugs that are more powerful than Plaquenil. But again, looking at the data, if patients like that are on Plaquenil versus patients like that are not on Plaquenil, and you extrapolate it out over years or maybe a decade or so, then the people who did not get Plaquenil or who stopped the Plaquenil may not fare quite as well. And remember, lupus is often a disease of women more than men and tends to hit people in their early 30s. So we're talking about being on treatment for this disease for 35 or 40 or 50 years. So it's not unusual to see someone who then could develop a problem 10 or 15 years later that might have been prevented potentially if they had stayed on their Plaquenil.
Right. So there seems to be a question about the brand name and generic name, and you had briefly mentioned about you writing prescriptions for the generic form, but can you talk more about the brand versus generic a little bit more, please?
Sure. So the original company that made Plaquenil, I think, sold it several times. So it's really relatively hard to get the brand name. The only difference that I have ever noticed between the brand name and the generic is that the brand name, at least in the past, was a little better coded. And some people that had a little bit of GI distress, little heartburn or stomach pain taking it, fared better with the brand name. In terms of efficacy, there is no difference whatsoever. And in terms of what the patients pay for the Plaquenil, many times if a patient asks for the brand name and they get it, they fall out of their chair when they find out that the cost is tremendous compared to the generic. So I don't think anyone out there should get the feeling that the brand name works better than the generic. I've never seen any data that brand name Plaquenil is better than generic hydroxychloroquine. The only difference I noted, as I mentioned a few moments ago, is with the coding, and it might be just a little easier on the stomach.
Thank you for clarifying that. So I think this brings us to kind of the hot topic for lupus patients. You know, we quite often hear in the office that patients complain that the side effects of their medication can be worse than the disease at times. But can we talk about the side effects of Plaquenil?
Sure. So let me talk about some generalities first. The main toxicity with Plaquenil is retinal toxicity. And that often is dose dependent. As I said, if patients stay on the proper dose of 200 milligrams daily, if they weigh less than about 135 to 140 pounds, and they take 200 milligrams twice a day or 400 milligrams once a day above that, in the situation of having relatively normal renal function, because there are some physicians that will reduce Plaquenil a little bit if someone has significant renal disease. The main toxicity is retinal toxicity, which is deposits on the back of the eye, which causes what's called a bullseye abnormality that an ophthalmologist can see. The first things that usually happen is that people start to have problems with their color vision. Changes, once they occur, tend to be permanent, but it takes a long time for changes to occur. So in essence, when I start somebody on Plaquenil, and I've decided after 8 or 10 weeks that they're going to stay on it, I have them get an ophthalmologic examination, which is basically a baseline, and then at least once a year thereafter. The American College of Ophthalmology recommends every 6 months. American College of Rheumatology, for the most part, has said once a year. If your eye doctor is just vehement about the fact that he or she wants to examine you twice a year, there's nothing wrong with that, but most of us just require an eye exam once a year. I'm also going to backtrack and say that there was an abnormality that was called a G6PD deficiency, which is an enzyme in people. And we were always taught that if that G6PD level was low, patients should not take Plaquenil because they could develop what's called hemolysis, which means breakdown of the red blood cells. That was something that was kind of dogma for 30, 40, 50 years. But about 3 or 4 years ago at Duke University, they actually put this dogma to the test and found that patients who had low G6PDs actually did not develop significant hemolysis. So some of the patients, some of you out there listening to this, have probably been checked for G6PD, and many of you, followed by younger rheumatologists, have probably never had that blood test checked. And that's because data now suggests that it probably isn't necessary. So the main thing is toxicity to the eye. The other thing that we can develop is what's called a myopathy, which is weakness of the muscles. And sometimes that weakness is difficult to discern from lupus itself, and sometimes difficult to discern from weakness that can occur from steroids. But many times, if there's no other reason for muscle weakness, usually the large muscles of the legs or the upper arms, stopping Plaquenil can be helpful. Because the heart is a muscle, there's also what's called a cardiomyopathy, which is very, very rare, where the muscle of the heart does not function well because of Plaquenil. I have been in practice and/or used Plaquenil since my fellowship in 1979. You can do the math. I've seen one patient in 40 years who developed a cardiomyopathy, and actually it wasn't even a lupus patient, it was a patient with rheumatoid arthritis. Okay, that brings us to this concern about the arrhythmias. Most rheumatologists, myself included, have never counseled a patient about arrhythmias in patients with Plaquenil, because I polled all my partners, have never seen a case of an arrhythmia in a patient with Plaquenil for rheumatoid arthritis or lupus. Now, the backdrop of COVID-19 is that there were more arrhythmias. But there are several things that are different here. Number one, patients with COVID-19 who get sick are sick. They develop sepsis. They develop hypoxia, low oxygenation. They develop electrolyte abnormalities like low potassium. These are all things that can lead to arrhythmias. The second thing is that many of the patients who had arrhythmias were taking Plaquenil and Zithromax. Zithromax alone has been shown to have what's called prolongation of the QT interval, which means that during the electrical activity of the heart, there's a potential rest area that would allow arrhythmias to occur. And most of the patients who had COVID-19 who took Plaquenil also took Zithromax. So they were on Plaquenil plus Zithromax plus had COVID-19, which is an entirely different situation than having lupus and being on Plaquenil. So I just encourage all of you out there that if you have concerns about an arrhythmia, that the concerns about the arrhythmia are dwarfed substantially by what should be your concerns of not taking Plaquenil if you have lupus. I hope that's kind of an overview, and if we need to delve into it in a little more detail, there's other questions that people have called in. We can answer those now.
Okay. So definitely, I think you've hit upon Plaquenil in the heart. Yeah.
One other thing.
Sure.
The Plaquenil dose that was used in COVID-19 was a starting dose of loading with 800 milligrams and then followed by 600 milligrams daily. I don't know anything about the weight of those patients, but a normal 70-kilogram person would never, for lupus or rheumatoid arthritis, take more than 400 milligrams daily. So not only is it a different disease, COVID-19 versus lupus, and the addition of Zithromax, which most lupus patients are not going to be taking on a regular basis, the dose was actually almost double to start. So all of these other variables are totally different than the average lupus patient taking Plaquenil. Leslie, I'm sorry to interrupt, but I wanted to get that point across.
That's very good. Yeah. So sticking to the lines of heart and lupus, this patient's been taking the medication for 10 to 30 years, and never have they ever been hearing of the side effects of the heart, and it's just kind of coming out now. So why is that? The correlation with, is it with the correlation with the disease itself or the medication?
It's exactly what I said. Rheumatologists have been using Plaquenil for 50 years or longer, and we've never seen any problem with any arrhythmias with lupus. The situation is totally different. The dose is basically twice what a lupus patient takes. It's taken in the concert of usually those patients on Plaquenil also received zithromycin, and they had COVID-19. And COVID-19 increases your risk for all sorts of problems because of sepsis, because of hypoxia, because of electrolyte abnormalities. That alone would lead to more arrhythmias. So we're talking about apples and oranges. And that's why I said, I don't know any rheumatologist that I've associated with for my entire career who ever talks to patients about Plaquenil. The only thing we usually say is, you need to have to get an eye exam regularly. There is a potential to cause some weakness in your muscles. If you develop that, let me know. And again, prior to a couple of years ago, I would check this special enzyme. And if it was low, and I've seen it low 3 times in 40 years, I shied away from using Plaquenil. But now I realize after the Duke University data that probably I could have continued those people. I could have put those people on Plaquenil.
Okay. You know, I think we've really hit upon all of the questions through your talk. And just one more comment with this is a patient is saying that they're scared of taking it. And what we're hearing here is that, you know, you highly recommend and it's a safe medication, but they're saying, I'm scared and I'm thinking of not taking my Plaquenil anymore. And it's more with the concerns of the toxicity to the eye.
Well, again, the toxicity of the eye is this. If you're taking standard doses based on your weight, and again, there are some physicians that will also reduce it a little bit if you have some renal impairment, and you're getting a regular eye exam, then there's nothing to worry about. I would tell that patient that if they're getting an eye exam once a year and they're concerned, they should get an eye exam twice a year. And that way, if there would be the very beginning of any deposits on the eye, it could be stopped, and early it's reversible. I will also tell you that most of the early toxicity is color vision, dark blue and black. And my understanding is that 25% of all men in this country have trouble with black, blue discerning. So I'm not trying to belittle it. I'm just saying that it's not like you take the medication and you could wake up blind a week later. This would be a very subtle abnormality with deposits on the back of the eye to take months and months and months and months to develop. And for some patients, and I have a few that are concerned about it, I just have them get an eye exam a little more regularly. Instead of once a year, I go twice a year. And if someone's even concerned about that, they could see their eye doctor quarterly. But again, if you have lupus, the data is that being on Plaquenil, you will do much better in the long run than without it. And with diseases that are chronic like this, especially with potential for long-term organ damage, you want to stack the deck in your favor. And Plaquenil is one of the good guys that's on your side. Steroids are one of the bad guys that really you should try to get away from.
Thank you for addressing the side effects. I appreciate it. So let's move on to the hot topic here that I know everyone's really been thinking about is COVID-19 and its relationship to the medication. You did kind of address, what's big in the news right now, but a question that I have here, actually, do you want to talk more just in general about Plaquenil and COVID-19, or would you like me to jump into the questions?
Well, just quickly, what I kind of said earlier was that the initial studies were in the test tube that Plaquenil might reduce the viral from replicating, but in the studies that they did, they found that it was not helpful preventative, and in the sick people that took it, they found that they did worse. So those studies were stopped.
Okay. So if they're taking it, they're not safe from the virus, right? It's not a safeguard.
Exactly. What you need to do is the triad of social distancing, washing your hands, and wearing a mask. Do not think that if you're taking Plaquenil, you're going to prevent yourself from getting the virus. And on the other hand, do not think that taking the Plaquenil is going to increase your risk of getting the virus, because some people read about the study where the people that had COVID-19 on given Plaquenil did worse. Those were really sick people in the ER where it was in the hospital in the ER where it was started in high doses. If you have lupus, you should stay on Plaquenil. If you develop COVID-19, I would still recommend continuing your Plaquenil while you're on it, while you have the COVID-19, unless your physician feels that you should stop it. Again, Plaquenil is not a major immunosuppressive. It just has mild immunomodulating effects. My concern and my partner's concern is if you have lupus and develop COVID-19 and stop your Plaquenil, if your lupus flared, then you'd have to go on steroids or maybe increase immunosuppression. And steroids and other immunosuppression would be far worse for someone with an infection than continuing on Plaquenil.
Right. So the fact here is we're stating it right now. It's that you're not safe from the virus. If you've been on Plaquenil for a couple months to a couple of years, it's to continue to stay the course and social distancing, hand washing, and all the regular parameters for everybody else.
And wearing your mask.
And wearing your mask, yes. Okay, so am I safe from the virus? You've hit upon all the questions related to COVID-19 and the medication. And it does seem that the heart is a big topic with the medication, but we've addressed that because that question kind of came up again underneath COVID here. But I think you have addressed everything for us tonight, Dr. Blatt, and I am very appreciative of joining together. I think this really does help our patients just decipher between fact or fiction of what's going on, and you've kind of laid down your knowledge, and we've put the disclaimer out there to check with your physician before changing anything.
Yes, absolutely. I would say you need to check with your personal physician. I am talking in generalities. Lupus is such a varied presentation with so many different organ systems and different levels of organ system and degrees of involvement and medications that you're on that you should always, always, always talk with your personal rheumatologist before you make any change.
That's right. Very good. Well, thank you. Everyone has submitted their questions ahead of time to discuss with you this evening, and I think we've addressed all of the concerns. So that brings us to a wrap for our Ask the Expert series on hydroxychloroquine. Say it for me, Dr. Blatt. I'm so sorry.
Hydroxychloroquine.
Hydroxychloroquine, thank you. And we have addressed the facts or fiction versus fiction tonight. And so I thank you for joining us, and anyone that is on our webinar, if you would please fill out the survey so that we can best serve you and figure out how to continue to best serve you, and you'll also be entered into a raffle tonight. So I appreciate your time, and stay safe, and I'm definitely masking out there, as I hope everyone else is if they have to go out and about.
Thank you
Thank
all
you.
for joining us.
Thank you very much. Have a good evening.